introduction slide. Give me just a minute.
Just a second, just activating the live stream. There we go. Next, we're going to hear from Dr. Fifi. This is somebody that everybody here knows very well, but I think worth mentioning her pedigree, just so you can see how much she's doing. She is Associate Professor of Neurosurgery, Neurology, and Radiology. She's Associate Director of the Cerebrovascular Center. She has become Co-Director of the Pediatric Cerebrovascular Disorders Program. She's Site Director at Mount Sinai West for Cerebrovascular Services and Co-Director of the Fellowship. She got her medical degree from BU, did her residency in neurology at Thomas Jefferson, and then accomplished multiple fellowships in vascular neurology, and then 3 fellowships in neuroendovascular surgery, including a pediatrics fellowship with Dr. Berenstein. And today we have the opportunity to hear about a very controversial topic that is becoming increasingly less controversial as new techniques and new tools are developed. So Dr. Fifi, looking forward to hearing your presentation.
Thank you, Chris, for that invitation. I'm glad that there were no funny photos shown. Let me share my screen. Is that seems to be the
That looks good.
It looks good?
Yep.
Okay. So yeah, I'm going to be talking about AVM embolization for cure. As we've heard, this is a controversial topic, and Chris, Dr. Kellner, has contributed to the controversy by having a chapter in the Humans Neurosurgery about this topic. Yeah, some of the slides there from that chapter as well. Let me go here. Yep, so these are my disclosures. None are directly related to this. So multiple options exist for the treatment of brain AVMs. We all know surgery, radiosurgery, embolization, and of course, observation. Embolization is traditionally has been used as an adjunct to surgery, but it's more and more, I don't know if extremely prevalent, but in certain centers and certain parts of the world use more for the complete treatment of AVMs. It has, of course, become standard treatment for some of our other arteriovenous type of malformations, such as dural AV fistulas and vein of Galen malformations. The rates of procedural and peri-procedural complications must be weighed against the natural history. So we often quote 2 to 3% annual risk of rupture for unruptured AVMs, and then about 4.5% for ruptured AVMs. And importantly, for ruptured AVMs, most of that risk is in the first year after a hemorrhage. 15.8% is a commonly quoted risk after the first rupture in the first year. And past studies looking at treatment versus medical management, such as Aruba, have produced a lot of controversy, but new technology and techniques have been developed since these studies. And at this point, the type of intervention is tailored to the specific AVM after discussion, ideally by a multidisciplinary team, such as how we do it at what we have at Sinai. So the history of embolization for cure is pretty long. This was a paper published by the group at NYU, which Dr. Berenstein was a part of in 1995. And these were 14 deep central AVMs of the thalamus and basal ganglia, so non-operative. And they saw a 15% complete obliteration by endovascular therapy alone, so fairly low. But this is a case example of the type of AVM that even back then, with the technology that was available, was able to be cured. So very compact nidus, microcatheter, in those days less trackable, but microcatheter placed in a deep feeder, and then injection of glue leading to complete obliteration. A recent systematic review was published looking at multiple articles talking about AVM embolization for cure, and they looked at in total 598 brain AVMs treated with curative intent, and what they found was a 58.3% complete obliteration rate with a 13.6% procedural complication rate and a 24% clinical complication rate. What they did note was that there was a more than 90% complete obliteration rate in carefully selected patients. So while overall the technique is not applicable to every AVM, these two articles using liquid embolic onyx published this one in 2012, where they focused on small or medium-sized superficial AVMs. They're able to achieve complete obliteration more than 90% of the time. So it really is a question of patient selection. And then in this article, this group in Chicago, they came up with a score, the arteriovenous malformation EMBO-CURE score, AVMES, and with the idea that this would help choose patients for which intent to cure with embolization would be valid and successful. So they looked at 39 patients retrospectively. It was validated on the same cohort, so not ideal, but the score consists of the size of the AVM nidus. You can see it divided into the traditional sizes here. And then the number of pedicles contributes to the score. The points are shown on the very right. And then the draining veins, number of draining veins 1 to 3, giving the lowest, and more than 6, giving the highest score. And then also including vascular eloquence as part of the score. So in using the score applied to those patients, they showed that with the lowest score, AVMES of 3, they're able to achieve complete obliteration 100% of the time. And then this falls as the score goes to 4 or 5, and then to very low once the score is greater than 5. And then the opposite kind of for the complications, the complete cure with no complications in the AVMs with a score of 3, and then low percentage of cure with high complication rate of 30% with score greater than 5. So this seems to be a useful tool to try to choose patients in which we should be using this technique. I'm going to go on to show some of the techniques that have been developed and are still under development for curative embolization for AVM. So the standard technique for AVM embolization has been transarterial embolic injection. And you can do this using a microcatheter, and then more recently with the development of dual lumen balloons, this is more easily achieved. There's a technique that's sort of a very advanced transarterial technique called multi-plug flow control. And that picture is kind of showing it here, where you place multiple catheters all at once into the arterial feeders and do simultaneous embolic injections. And I'll show their paper in a couple slides. And then the transvenous techniques. So this is going back into the vein and then trying to retrogradely penetrate into the nidus. That's another technique that's I will show a case example of, and then what's recently been published is something called the pressure cooker, which is basically a way to force the embolic agent backwards. So before I show those techniques, I'm just going to talk briefly about the devices, because that's really been a big advancement and really allowed us to really use these techniques. The technology that's coming out every year, as you know, for stroke, it's been very good, and it transformed the field, and probably will do the same for AVMs. So the detachable tip catheter was something that came out several years ago now, but has been very helpful. And then the dual lumen balloon catheter has been very useful. And of course, embolic agents have advanced and continue to advance as time goes on. In the United States, we really only have 2 on the market right now, but there's multiple agents that are used around the world. This was a slide from another conference, but the Apollo Onyx delivery microcatheter was developed to be detachable, so you can see what it looks like on the table, but what you see here in the detail is that it's a single lumen end hole microcatheter. So it's the Onyx comes out here, and then the very tip of it is held by friction onto the body of it. That detachable tip varies in length. We have 1.5 or 3 centimeter detachable tips in the United States. In Europe, they actually have 6 centimeter on the market. But basically, once you inject the embolic material, and sometimes, and if you leave the catheter there long enough, the tip of the catheter will become essentially glued into the cast right here. And so the once it is glued in, is sometimes you can trap the microcatheter. So with this kind of detachable tip, you simply pull back, and once it reaches passes the force necessary to hold it here, it will detach, and you can remove the entire thing. So this stays in the patient, and this part of it will come out. So that allows you to do more prolonged injections with the embolic agent. The dual lumen balloon catheter has also been a big advance. This is a illustration of the newest one that actually we started using, I believe, last year. So it's really only been on the market for a short period of time. The distal tip, the reason why this took a long time to make is that the distal tip is 1.6 French, so very, very small. And despite having a balloon on it, it's very navigable. So you can advance this into vessels, and I'll show some examples, inflate the balloon, and therefore allow all of the embolic agent to go forward into the nidus of the AVM without coming back and causing reflux. This balloon and the mini balloon that we have is 9 millimeters in length, and it's about 2 millimeters in diameter. And then embolic agents, we have, like I mentioned, NBCA, which is acrylic. It's like similar to crazy glue. We have Onyx, which is a copolymer of ethylene and vinyl alcohol. It's in a solvent, and it polymerizes it when you inject it into the body. This agent called Phil, which we're currently using here at Sinai in a trial, is essentially the same agent, but it's slightly in a different solution. And then there's others that are also in trials in the US and not yet FDA approved, but used in other countries. I'm not going to go into too much detail. This was the first report that showed of onyx embolization via a dual lumen balloon catheter. And that we did this in a mandibular AVM, so not in the brain, but close. And you could see here extensive AVM in the mandible, a balloon in the a balloon catheter in the artery here, with the balloon inflated, and then with the balloon inflated, the ability to penetrate deeply and into the vein of the AVM and fill in the venous pouches in the bone. So that is one technique that is still currently in use, and with the new mini catheters, I think that it's going to be a significant advancement in our ability to cure AVMs with this technique. And then this technique, without the balloon catheter, this group in Turkey has been doing curative AVM embolizations for quite some time, and they published a report looking at 350 patients, and basically similar numbers to before, showing 51% complete obliteration, 1 mortality, and then on delayed follow-up angiograms of the patients that had been completely obliterated, 2 out of 178 had some small recruitment. So they thought they were cured, but they had small residual or recruitment on the delayed angiogram. So it's a small number, less than 1% or about 1%. And that group, they moved on to using, like I said, this multi-plug flow control technique. And I just wanted to show it in bigger detail. It is a very complicated technique. So this is an AVM here that they use this with. It's being on this picture. You see the AVM has feeders from multiple middle cerebral artery branches, and then over here posterior cerebral artery branches. This picture shows, I believe that they use, I can't remember, but it looks like at least 4 microcatheters going into the multiple feeders. And then the reason why you're doing that is that in this kind of AVM, if you start injecting into the nidus, you may go through the nidus and then end up into normal parenchymal branches. So in having microcatheters in each of the feeders, you don't go through the nidus and back into another feeder and into normal branches. So you have injections of the embolic material, in this case onyx, occurring from multiple branches simultaneously or in turn, but going from one to the other until you make sure that the entire nidus is completely filled. And this is a case that they reported. We have not used really this technique here. And then the transvenous techniques, there's been, this is kind of the I guess recent kind of advancement that's becoming more and more popular as a way to completely cure an AVM. There's still and there is controversy, and the rates of complications were significantly higher in the beginning, now coming down. But at any rate, in the reports in the literature, this group actually did a review of the articles that had been published up to that period of time, which was about 3 years ago. And so the first report of this technique was actually quite a while ago, 1999, but not much was, this was using coils, which we don't really do anymore, to completely obliterate transvenously. This is because, as you might imagine, you should try to actually get the nidus closed, and it's very difficult to do that with coils. And then the technique advanced to using onyx, and then squid. So these are liquid embolics, like I was describing. And then recently, the technique has evolved to really involve combination of coils, onyx, and different catheters. So in this review, it was a small number, 68 patients, but 63 out of 68 had complete obliteration and about 4.3% complication rate. And to speak a little bit more about the technique, so this group developed something called the pressure cooker technique for brain AVMs, and that is basically where you go transvenously into the vein of an AVM. So the catheter is, 2 catheters are in this vein here. And then you create a plug using coils and sometimes using glue to prevent, as you inject the embolic material, to prevent it from coming back at you. Because of course, the flow of the AVM is backwards along the catheter. So you coil off the vein first, which is obviously when you're operating or at any other time, you would not want to coil off the vein of an AVM first. So when you do this technique, you're doing it with the absolute need to cure the AVM after you do that. And so you close off the vein. This prevents the embolic material from coming back at you. And then you inject the embolic material retrogradely through the nidus until you fill the entire nidus without getting into normal brain tissue. They recently published their results using this over a period of, I think, the last 7 years or so. And so they published 51 patients. Most were Spezzer-Martin 3 to 5. They were deep-seated 60% of the time. 33% had prior transarterial treatment, which is sometimes necessary to do this technique. And but 96% went on with the one session to be completely cured, the one transvenous session to be completely cured. There is a 6% rate of intracranial hemorrhage, no deaths, and 1 permanent significant morbidity. So it's a promising technique. I think the importance and the risk of using this technique is that you have to basically completely get rid of the nidus. So it's a very technically challenging kind of procedure to do, but you have to, once you start this, you have to completely get rid of the nidus in that treatment. So I think I'm going to show some case examples just because these are kind of abstract concepts without looking at a couple of cases. And I don't know if anyone has any questions right now, or I should just go show the cases and we can do the questions at the end.
I think going forward with the cases,
Yeah.
and just to give you a sense of time, about 10 minutes, including questions.
Okay, so I'll try to show quick cases. So yeah, this is a patient, a 56-year-old man who presented with unruptured AVM. He had it discovered because of increased migraines after COVID. So this was actually discovered in 2020. This is the angiogram showing it's a medial frontal AVM with one real feeder. And then this is a navigation of a scepter, so the balloon catheter coming up into that major feeder to the AVM. And here the injection right before that navigation from a little bit more proximally showing the feeder, the nidus, and then You know, in any AVM embolization, you want to know exactly where the vein begins and where it's going. So this is after the initial embolization. The balloon is inflated, the onyx went forward, it went through the nidus, and it has filled the vein. So once you're filling the vein, you have, like I said, you have to go for complete cure. Importantly is just showing this as a teaching point. There's some nidus left, so you check during the procedure, are you done? Is there still nidus? If you see something that looks like nidus, you should keep going, because that could bleed if you were to leave this there. So in injecting more of the onyx through the balloon catheter, onyx is traveling through the nidus and then eventually filled in that section. And so once you see that, you can do your angiogram. And if you don't see anything that looks like nidus anymore, you're done. So this patient had complete obliteration of that AVM. He actually recently had his 1-year follow-up, and it looks great. And then another example, this is a 31-year-old man who presented with hemorrhage. He did have a session of transarterial embolization for an occipital AVM, and then he returned for transvenous. So this is a left vertebral artery injection, left PCA feeder to the occipital AVM here. You see it's a very compact nidus, one draining vein. So the embo cure score would be low. And that is, there was glue already in one of the feeders. This is the remaining feeder. This is again navigation of a catheter, balloon catheter, up into the feeder. And you can see from the selective injection, compact nidus straight into a vein. This was one of our first transvenous AVM, brain AVM cases. So we did a 8 French guiding catheter in the superior sagittal sinus, the detachable tip catheter deep into the draining vein, and then another catheter ready to put coils if necessary. And then here's transarterial onyx injection. And there was still some nidus filling towards the vein. It's a little hard to see here, but this was thought to be some nidus here. So then injected onyx retrogradely through the transvenous catheter, and that's, you can see it filling in, and then finally it filled downward and into the nidus. And then that's the final cast, and that's the angiogram after. And he also had, this was a few years ago, he also had follow-up angiogram that showed permanent or long-lasting obliteration. And quickly, this is a 22-month-old we recently treated. So this is a last stage treatment after transarterial sessions for vein of Galen malformation. And this is the initial angiogram showing the vein of Galen malformation. After 5 transarterial sessions at 22 months, this is the glue that's there from the transarterial sessions. And this case may be a little bit complicated, but we can maybe show it in detail at another time since we're running short. But after multiple sessions of transarterial, you see how the vein has become very small. So we can basically shrink with transarterial sessions this sort of vein into this sort of vein, and then this sort of vein becomes amenable for a transvenous last session to cure the AVM. And here is our 8 French catheter being navigated up, and this time placing it into the falcine sinus, which drains vein of Galen malformation. And after that is placed, having a microcatheter in one of the feeders, looking at the residual and the the venous catheter here. In this technique, pressure cooker, we place a detachable tip catheter that you're going to inject onyx in first, or actually this is, yeah, you can place it first or second, but the second catheter you place is one that you're going to put coils with. And so there's two catheters through there. This is a coil mass being formed. This is acting as a backstop for any liquid embolic that you're going to try to inject retrogradely. That's the coil mass. And then looking now from an AP projection, that's the coils that have been placed. The coiling catheter is gone. And you have onyx being injected to fill in that coil mass and create the backstop. And once that backstop has been created, what you then see is, as you continue to inject onyx, you then see retrograde traveling of the embolic material through the nidus, and then towards the, in this case, it was going towards the microcatheter that was in the arterial side. At the end, this is the onyx cast, and you can see that the AVM is obliterated. This was a procedure we did a couple months ago, and the patient will come back. So I'm going to stop there in the interest of time. Those were kind of quick. You know, techniques have advanced, and we have this new score that will help us choose patients. I think it's not just the score, but expert consensus by multidisciplinary team is very important, and this knowledge and ability to do this is rapidly advancing. Okay.
I don't think that it's fantastic work. I don't think there's time to do justice for questions, so it needs to be discussed, but I don't think there's time at 9 o'clock. Maybe we can come back to this issue and you can do a recap or something.
Sure, yeah, we can do some of the cases in detail.
Yeah, that'd be great. Thank you very much.
Thank you.
Yeah, thank you, Joanna.
Okay, we'll stop here.